thank you so much, Dr. Ng, for your great talk this morning. I really enjoyed that, and I'm hoping that most of you, like me in the audience, were very inspired by the scope of these types of research programs. I always come away from these talks very inspired and encouraged, but often also overwhelmed at exactly that, the scope of it. And if you're interested in implementation science and knowledge translation research, it can be quite daunting to think about how to get started in it. And so what I'm going to try to do for the next hour is pick up on a lot of what Dr. Ng talked about in terms of thinking about implementation research and particularly in balance and fall prevention. And what I can talk to you about is where do we get started? What are those key ingredients that we need to set up and have in place methodologically, fundamentally, foundationally in order to be able to engage in an implementation research program? And I can speak to you in the context as someone who has done a lot of balance and fall prevention research, starting from some very sort of fundamental kind of basic postural control studies, moving into more sort of clinical application and mobility studies, and now for the last few years have really been focused on thinking about how do we take these fundamental components of postural control, fall prevention, mobility, and how do we make them work in the context of an implementation study. So I'm very excited to be able to talk to you about some of these things today. And so really what we're talking about in the next hour is planting seeds, right? So thinking about if this is the kind of research that you might want to integrate into some of what do you do, where do you get started? So these are what my plants look like in Winnipeg right now. They're just getting started. But really it's about planting seeds today because these studies are often what I'll say is deceptively complex. You start out and the research design, the methodology, compared to some of the technologies and analyses that a lot of you are doing are relatively simple, but it's often the conceptual foundations behind them that are so critical for sort of putting those pieces together and moving forward. And that's really what I want to sort of advocate as we think about growing this discipline of knowledge translation and implementation, really applying the same type of conceptual rigor to what we're doing in these types of studies that we're already doing when we're thinking about what are the fundamental elements of postural control, how do we prevent falls, those same types of rigors where we want to go. So I'm going to build on Dr. Ng's definition of implementation and really have a nice example, I think, to really kind of get our heads in what we're talking about when it means to try to implement evidence into decision making. We're going to talk about what some of these key ingredients are when you're moving towards that angle, giving you some examples about how we've done this in balance and fall prevention research, hopefully, again, to spark some interest and ideas for you. And finally, I'm going to talk about a couple of solutions for when you don't necessarily have all of the ingredients ready and in place yet, and what are some of the strategies that you can be applying in your research to help get you there. So my take-home messages, we'll start with them and hopefully you can keep them in mind throughout the talk and these will reinforce themselves. So I believe very strongly that research at any phase of the bench to bedside to community continuum can be implementation minded. And so maybe you're not right there yet, but if you can starting to be thinking about what are the things that ultimately my end users are going to need to be able to use this evidence, I can be incorporating those into my research designs now and building all of those pieces and putting them together. Second message is that unlocking or gathering all of your key ingredients is essential pre-implementation intervention, pre-study. And we'll talk about this as we go along, but very much thinking about what are the conceptual foundations of implementation science. Reviewers on these panels very much want to see that you've done your homework and you have all of these pieces in place. And very much to the point we were talking about a few minutes ago about not rushing, okay? And so applying those same types of rigor to what you're doing is really essential. And so what it ultimately comes down to is that your missing ingredients, those are oftentimes what I would say are your next research step. And so we'll talk about, when we look at these various ingredients, if you study yet. What you need to do is assemble that next piece to help you move forward. So, first off, what is implementation? We started to talk about this with Dr. Ng, and what I actually have for you, I'm going to let this video do the talking for me. This is a video that was produced by the Ontario Centre for Excellence in Child and Youth Mental Health, and one of the grad students in my course this year found this group and this video and brought it to our class. So it uses an example that I think will really hit home for many of us. What really hits home about that video is it's really about the process, right? Implementation is the process of integrating evidence-informed solutions or research findings into our everyday work. So it's not it's not exercise, it's not even the treadmill, it's how are you going to use the treadmill to do the exercise to improve your health that you want to do, right? That's the real sort of nugget of what we want to be thinking about in implementation. And implementation studies and research are about how do we understand and facilitate that process to get that ultimate outcome that we want to. So it really is the how of translating knowledge into practice. And so we saw this definition earlier as well. And so when we're talking about implementation research, we're talking about the study of the methods to promote systematic uptake of clinical research findings and other evidence-based practices into routine practice, and using that to improve quality of care. So the assumption in implementation research is often that the foundation for what it is you're doing is already there. So it's not necessarily your sort of fit principles of exercise, it's how are we implementing those. The assumption is that we have this foundational evidence at ready already. So the key ingredients for implementation research, how do we move there? Where do we need to go to do those? And so essentially what I'm going to be doing for the rest of my talk is sort of funding it around this really helpful paper that was written by Enola Proctor and colleagues back in 2012 and published in Implementation Science. And this I have found to be one of the most helpful papers I have ever read, and I use and apply these ingredients in my work quite frequently. And in Manitoba, I operate out of the Centre for Healthcare Innovation, which is our Manitoba CIHR support unit. So we do a lot of consultations with researchers, and a lot of people will come to me and say, I'm really excited, I want to do a KT study, I want to do an implementation study, and often the first thing I'll do is hand them this paper and promote a little bit of self-reflection to say, okay, how are you? Where are all of these ingredients? Can you answer all of these questions? This is going to help give us a roadmap for where to go. So even though this paper is specific to writing implementation grant proposals, I found it to be very useful for thinking about implementation research planning on the whole. So in Proctor et al., they talk about these 10 key ingredients for implementation proposals. And don't worry about all of the text here. We're going to go through several of these. So 10 ingredients. What do you need to even do implementation research? You need to be able to demonstrate evidence of a care or a quality gap. You need an evidence-based treatment that you want to be implemented. You need a conceptual model and a theoretical justification. You need to be able to demonstrate that the priorities of your stakeholders are addressed and are engaged in this work. You need to be able to demonstrate that your setting is ready to adopt a new treatment or a service or a program. You obviously need an implementation strategy itself. You need team experience with the setting. You need to be able to demonstrate the feasibility of your research design. You need an appropriate measurement analysis section, just like many studies. And finally, you need to be able to demonstrate that your policy and funding environment is amenable to the type of change you're producing. And so for me, what is so sort of interesting and really well laid out in this paper is that when we look at these ingredients in detail, just over half of them are very much about the fundamentals and establishing all of these components in place before you even get to the point of thinking about your implementation research design or your evaluation strategy. And so this is where often when researchers come to me and they say, I want to do an implementation study, these these are very much the ingredients that I often will challenge them and say, do you have evidence of all of these in place? Because if you don't, an implementation research panel is going to sort of send it right back to you and say, what is your justification for what you're doing here right now? So you have to build the ingredients first in order to even get to those sort of research design phases. And so kind of thinking about this group as an origins of balance and fall prevention cluster, and thinking about what will be the kind of most potential use for you today, I'm going to be focusing my talk on these initial ingredients, because I'm going to make an assumption, knowing where I started working in this field, of what were the ingredients that I had to build up. And when I started in this I guess, sort of area in my postdoc, I very naively thought, oh yeah, I'm totally going to do a KT trial in the course of my 3-year funding. And it took to the start of my first job to be able to get all of those components in place. And so in many cases, slowing down, being able to demonstrate all of these components are very much your initial studies. And the other thing that I always sort of say is really kind of neat about this as well is because they're foundational, no matter sort of where you are in your research program, these are ingredients that you could be kind of pairing with more basic postural control research questions, or while you're establishing efficacy of something, you could be simultaneously demonstrating or making the case for all of these ingredients. So when you're ready, you've got them all sort of laid out. So, ingredient number 1 that is really important to address, the care or quality gap. So are you able to demonstrate that there is a gap in care? We saw Dr. Eng demonstrate some of the gaps that they identify in stroke mobility research and care as well. And so essentially what you need to show first and foremost is that there is a need for the solution that you are offering. This can be done in a number of different ways methodologically, so it could be at the healthcare provider level, it could also be at an organizational level, it could also be at a population level. So one of my favorite examples of a care gap in fall prevention actually comes from BC, and this was a study published in 2016 by Salter and colleagues from the Center for Hip Health and Mobility. And it was a fairly small study, but it really sort of very elegantly illustrates a lot of these principles. So they followed 54 older adults who presented to an emergency department with a fall-related injury. And in the course of identifying them through their presentation at the emergency department, pulled out the American and British Geriatric Society guideline, best practice guidelines for fall prevention care. And they assessed whether or not these 54 individuals who presented to the emergency department with a fall received care consistent with these evidence-based guidelines. So did they receive an assessment from a geriatrician? Were they screened for fall risk, balance, strength, all of these things? And so one of the first key findings was that they found was not one individual in this study received care consistent with these international guidelines. So right away we can start to say, oh, okay, we have a problem. We can see some gaps here. They followed that further and followed these folks over the course of the next 6 months, brought them into the lab and did a number of additional tests on them and looked at where their referral patterns were going as well. And what they found, again, was that just 2, 6, 8 out of the 54 received some care consistent with the guidelines over the course of the next 6 months. The vast majority of these older adults did not ever receive any care consistent with the guidelines, and accordingly a number went on to experience a number of additional fall-related injuries and fractures. So as a case for moving forward with implementation, this is quite compelling, right? This is the type of data that we need to be assembling and kind of building in order to convince CIHR to give us $500,000 or millions of dollars in order to move this type of research forward. The data-driven aspect of it is really critical, sort of as an individual researcher or PI saying, I know that this is not happening, is not going to be a sufficient sort of justification for moving forward. So one of the things that we've done in our work, again, is sort of pairing postural control science with this type of work. And so back when I started, we used the systems sort of approach or framework for thinking about postural control, breaking up that concept of balance into many more of its detailed components. And we decided to focus on, well, that's what we know a little bit about what's going on in primary care. How do physiotherapists think about balance, and what are they doing when they're assessing and treating balance? And I really wanted to get granular here. So what we did was we surveyed physiotherapists across Ontario, where I was at the time, and asked them, how often do you assess and treat each of these individual components of balance in the course of your practice? Which measures do you use to assess them? So on and so forth. And the results were, again, to many were not necessarily that surprising. Those of us who worked in the field could have probably predicted a lot of this. But what I was able to do was assemble the data as a case for moving forward. And when we surveyed over 350 Ontario physiotherapists, what we found out from them was that less than half, just 41% of them, reported to us regularly assessing reactive balance. And so this is the one time I can do this talk and not have to take 5 minutes to explain what I mean when I'm talking about reactive balance. So I'm very happy to be able to move forward with that today. But knowing what we know, and in contrast to static stability, dynamic stability, balance in walking, therapists reported to us that they did those kinds of things all the time. This was very clearly a gap in their practice. And when we connected to the evidence that we have about the importance of our compensatory postural reactions for avoiding falls and all of the biomechanical data that we have, this is very clearly a gap that has not made it into frontline physical therapy practice, at least at the time, in Ontario at the time that we did the study. But the skeptics sort of said to me, well, we also know that healthcare providers overestimate the performance of a behavior quite significantly. So while I was saying, this is terrible, less than half of physios are regularly considering this component, we knew we could strengthen this even further. So then what we did was we went and we actually pulled the health records of older adults undergoing inpatient rehabilitation in an urban Ontario hospital. And what we found there was essentially, I think it was one chart out of all 250 that we looked at, had evidence in them of reactive balance being considered and documented in their practice. So really sort of, again, thinking about building the case for why do I even need to be working in this area, this is a very sort of strong data to help support that. We also, just to sort of close the loop on this was originally done back in 2010. We followed up and replicated the study in 2014 in Saskatchewan and observed similar types of numbers as well in terms of what Saskatchewan PTs are assessing and treating. And what I should also add up is we've also now completed a fourth study, to your question, Steve, where we surveyed physical therapy curriculum programs in Canada and the United States, asking them, what do you teach about balance? Which of these components do you teach? Which measures do you teach as well? And it's interesting what sort of keeps coming up. So again, we hear people reporting to us that they are thinking about these concepts and training them at a very high level. When we ask specifically which clinical measures do you provide hands-on training to your students, what we would see is we see a lot of Berg balance scales and time up and go tests. And if you're familiar with these tests, you'll know that these do not explicitly target reactive balance. So again, the factors and how often, where you can sort of target these issues can go back very, very far along the chain. So, ingredient number 2, is there evidence for the efficacy of the solution that you are proposing to implement? And so this is a really sort of critical concept in implementation science as well. You need to, when we're talking about implementing something at a system level, even at an organizational level, asking clinicians to maybe reprioritize some of the things that they're doing over other important health behaviors as well. We need quote-unquote strong level of evidence to do this. And so in implementation science, there's a very strong preference for systematic review level evidence. So on the left here is that very sort of traditional kind of evidence pyramid for quality of evidence. And so as I say, systematic review levels really are considered the gold standard. Some people would say they're even considered like the cornerstone of knowledge translation. If you are proposing to change the world, this is the level of evidence that you have out there, that you need to have out there. Now, I can tell you, certainly where I am working, not all of the, not everything that we have is at that level of evidence yet. So often you need to really sort of think about what is the right implementation research question right now. The subsequent components of this figure here, there's some new debate going on right now that you might want to read about not necessarily always putting systematic review level evidence at the top of the hierarchy, rather sort of using that as a lens, as we see on the bottom here, to interpret some of these other types of studies as well. So again, thinking critically about where the research that you work in, what is the level of evidence at? Often we do need to sort of pause as the research producers and kind of thinking about what can I say? Where is the level of evidence at? In balance and fall prevention, we have lots of systematic reviews to choose from. The most recent one just came out, the most recent Cochrane review just came out in 2019 by Kathryn et al. Looking at exercise for preventing falls in older people living in the community. And the evidence case has been building quite strongly here for the last few years now. And it's quite clear now that at least in community dwelling older adults, exercise that particularly focuses on balance reduces falls. So again, from an implementation standpoint, in community dwelling older adults, we have a fairly strong case to stand on. And there's also new methodologies and analyses coming out all of the time as well. So I'd be remiss if I didn't sort of point out a review I was involved in the last few years, where we applied some new statistical techniques to the fall prevention literature and conducted a network and meta-analysis, and it was really exciting to be part of this process. So for those who are not familiar, network meta-analysis builds on a limitation of traditional systematic reviews and meta-analyses, which limit you to comparisons of two interventions that have been directly compared head-to-head. And what a network meta-analysis does is uses a lot of complicated statistics to compare interventions that have not been directly compared. So you can compare multiple interventions, and you can use indirect comparisons as well. So that allows us to put in all of the interventions that have ever been applied in fall prevention to find out what are the most effective falls. And consistent across the literature, 3 of the 4 most effective treatments that were found when we did this analysis came back to exercise as well. So again, depending where you are, what is your population and your setting, there's lots of consistent evidence coming out. And I'm really excited because what we have also done in this project is blown up this concept of exercise as an intervention in much more detail. And we're able to now compare 25 different exercise components, including all of the many components of postural control and balance, to find out which are the most effective components of exercise as well. And so we just got those results last week. I'm very excited to be putting those together. So, third ingredient. Does your implementation project clearly identify a conceptual foundation? And so this, I will go back to what Dr. Eng was talking about very much. Implementation science is quite theory and conceptually driven right now. And we could challenge that, we could debate the utility of that, but really this is what it comes back to, right? And if you think about implementation being a real sort of new and emerging discipline, it's trying to move of what are the very sort of implicit common sense things that we're trying by trial and error to moving towards having a very solid and substantial foundation for this. And in implementation science, it's very much argued that this is having a solid conceptual foundation is what is going to allow us to move the science forward, to find out what are the generalizable components that allow us to build our knowledge moving over. So one of the other most helpful papers that came around in 2015 was written by Nilsson. And when I first started in this field, new theories and frameworks were coming out all of the time. And when you sort of read them and making sense of all of the various implementation frameworks that were out there was extremely challenging. And this brilliant person kind of took a look at the landscape of implementation frameworks and organized them, and which really has been very helpful clarifying. So this is another very helpful paper as a starting with. And so what we can think about is the various implementation frameworks out there is falling into generally one of three categories. The first is those that are essentially process models, and these help us describe or guide the process of translating research into practice. And so the knowledge to action framework by Ian Grant that we talked about earlier would be identified as one of these process models. And I usually will talk about this framework ad nauseum, but I won't today, and suffice it to say it's a very useful and helpful framework. Second class of implementation frameworks we need are those that help us understand or explain what influences implementation outcomes. Okay, so what are all of those various barriers and facilitators that is going to influence implementation when we're talking about it? So Dr. Eng mentioned CFIR, Consolidated Framework for Implementation Research, is one that is getting a lot of attention. Another one that we have used, and I'll talk about a bit more, is called the Theoretical Domains Framework, which is a framework of behavior change specifically for health professionals. And so thinking about when we're trying to get therapists to implement new behaviors, adopt new measures, things like that, that's been very helpful to us. And then last but not least, there are these frameworks that focus on evaluating implementation. So the RE-AIM framework that we talked about earlier is one of the sort of classic examples of that. So you need to do your homework, you need to go read about all of these frameworks on their own and sort of understand how they apply to you, but I found this to be a very helpful kind of roadmap. And typically what I will say to my students is we need at least one of each of these. You want a process model to help guide where you're going. You need a determinant framework to think about all of the things within where you're going. And then you need an evaluation framework as well. And so if you can sort of separate your thinking, that can be very helpful. So here I'm going to now kind of sort of blend a couple of the ingredients together. And these are the ingredients around your stakeholder priorities and engagement, site readiness for adoption, and that larger policy environment. And so really what we're thinking about, again, at the stage of implementation is, do you have evidence that your stakeholders are engaged and involved in this process? Are your priorities aligned with them? So who wants to make this change? Is it me as the researcher who says, I've got all of these theoretical arguments of why people should be doing this? Or do my partners agree with that? Because you're going to have a lot more success if the targets of what you need to get done are on board and share those priorities than if you, as the sort of lone researcher out there, are really sort of advancing this agenda on your own. And you can approach this both in a data-driven way and also from a partnership approach as well. And so one of the real sort of critical things that we did back in our very first survey of balanced assessment practices in physiotherapists was, as part of the survey, we asked them very simply, is improving your assessment of reactive balance a priority for you? So, confession, knowing what was probably coming, I would say this was a hypothesis within the study. We anticipated that we were not going to see a lot of reactive balance measurement, so we added a question, neutralized with a number of other questions, but asked ask them straight up. And what we found was overwhelmingly, the therapists who participated in our study identified this gap in reactive balance as well. So we could make the argument sort of conceptually and theoretically, but the fact that the majority of my participants also acknowledged and understood this gap as well was really critical data for moving forward and making this case. And so actually this question was really sort of the fork in the road about how we then carried on over the next sort of set of years. Because if the therapists that we had asked in this study said, no, I'm not interested in improving my assessment of reactive balance, that would have led to a very different intervention if I did need to build knowledge and their attitudes and their awareness about the importance of reactive balance. But I was able to demonstrate that no, they're going to be on. We thought they were going to be on board with this. So really, sort of again, pulling those pieces apart and thinking about them is critical. But you need to move on. But you need to move on from there as well. And it's really about that partnership piece and the engagement piece. And so this is a cover image from an issue of JAMA Pediatrics that I was involved in writing a commentary for several years ago. And so we really worked with the illustrators here to really think about who are all of the many individuals at play. So again, you can't necessarily have those of us as researchers at one end of the continuum and those patients and families at the other end. It really is a partnership, and no individual can implement something on their own. And so I'm sure probably many of you share this philosophy and work implicitly in a lot of what you do to engage this. And so what we're trying to do in implementation science is take that from a very implicit way of working to how can we be more explicit about it, and how by being more explicit can we understand what some of those critical factors are. And so this is what's known as the sort of spectrum or levels of engagement that's been published by the International Association for Public Participation, or IAP2. And so what they talk about is the idea is there's many different ways to engage, and there's very much of a spectrum of engagement that moves sort of, for lack of a better word, at the lowest level from an informing component through to consulting, involving, and at more higher levels sort of actively involving and eventually sort of empowering our end users to be sort of driving the agenda and making those final decision making. So I think for a lot of researchers, we're probably down here often in the consultation phase quite a bit. And so kind of thinking at an implementation research level is, can we demonstrate to these types of panels or in our planning that we are actively collaborating? Are our end users partners and involved in the decision-making processes? Because if we think about sort of factors influencing implementation, we have to get them on board. So those are very much those kind of really sort of preliminary foundational pieces that we need to get going. And so again, this is all even sort of before we get to that what is the actual implementation strategy and process that we want to do. We just finished a literature review for a chapter on implementation of balance and falls as evidence, and it was really interesting the number of studies that I came across. The title said implementation of a fall prevention intervention. They published on it, and there was actually very little about what was the implementation strategy. It was all about, this is the exercise protocol, for lack of a better word, and we implemented it in 30 centers across whatever country, and this was the outcome. But I actually know very little about the implementation strategy. And so moving forward, if you're submitting this to me and I'm on the CIHR panel, what I'm looking for is, how did you come up with this? What is the intervention, and how did you come up with it? So in our balance example that we have been sort of working through, one of the sort of key things, have you mapped out the barriers and facilitators specific to what you're trying to do? So in our initial work, when we surveyed physiotherapists about, okay, you're not measuring reactive balance consistently. You say you're telling me that that's a priority for you to address and improve. So what has prevented you from assessing reactive balance in the past? What do I need to overcome in order to facilitate your ability and willingness to adopt reactive balance measurement? So we identified, therapists in these studies identified a number of factors for us. So lack of knowledge was part of it, but they also perceived that they did not have tools for their appropriate population. They didn't have access to them in their settings. Maybe the tools were unavailable, lack of time, all of these sort of things. So this is really what I needed to sort of figure out. And if we couldn't address these, maybe I needed to go out and develop a new tool for assessing reactive balance in the clinical setting. We did some other work to sort of find that out, but suffice it to say, you have to figure out what those factors are. And so what we did for developing an intervention here was then we took our barriers and facilitators to reactive balance measurement that we had identified and mapped them to one of these implementation determinant frameworks, the theoretical domains framework. And so as I said, this is a framework that is focused on the behavior of health professionals, right? So I want to target physiotherapists, what do I need to do? So when we mapped the factors we had identified onto these framework components, these were the components we needed to target. And another really helpful component of this framework is that they've also mapped what are the recommended behavior change techniques that are associated with each of those components. So we were able to determine what exactly were the techniques that we had to do in order to target to the physiotherapist. We then paired that with a clinical measure of reactive balance that required no equipment, had established validity and reliability, demonstrated in a number of populations, and collectively then used that to develop an intervention, a behavior change intervention for physiotherapists, which included a series of activities over a 12-month period. It was not just a one-off, here's what you need to do. It was a series of interactive group meetings where we provided both the foundational information but also hands-on practice. We met with them every 2 months to say, how's it going? What do you need? What do we need to practice? What are the challenges you're experiencing? We had on-site local champions who were actively engaged, both as members of the research team, but kind of on the ground. We also did a lot of work to get the health records modified, to get the measure right in the chart. So that was the intervention, and all of the sort of foundation that went into that was really critical. And this work a very clear sort of pathway back to why I anticipate and why I would hypothesize those components would be successful, not necessarily. And that's really when we talk about the conceptual foundations, what we need to build. So, solutions. So, again, hopefully there's a lot there for you to work with. And my biggest sort of solution that I like to advocate is that the first thing you need to do is start with the key ingredient that you need next. And if you don't have that next, that's okay. All of these are individual projects in and of their themselves, and kind of building stepwise towards that is really valuable in the end. Another solution, and then the sort of two other kind of solutions that I would like to pitch for you today is these hybrid research designs that simultaneously look at effectiveness and implementation. And so this is a new sort of class of studies that are sort of coming out and gaining a lot of popularity, that they allow you to look at interventions both in the real world as well as the implementation strategy at the same time. So if you're really eager to get going, this is often what we would be sort of pitching. And so there's different ways where you can both sort of you can either focus on either your intervention effectiveness or the implementation strategy, or look at equal focus as well. And so these are good interventions, I think particularly in rehab, when we have minimal risk studies where you have at the very least some preliminary evidence of your effectiveness, as well as having probably good partnerships, good face validity levels
for the setting that we want to go into. So in sort of getting ready for this talk today, I came across a really excellent protocol that's applying one of these hybrid designs in fall prevention, led by Lindy Clemson. So this was published back in 2017, so this might be something to check out in more detail. And you can see how many of the key ingredients they have even in sort of setting up their protocol as well. Last but not least, integrated knowledge translation. It's a term that originated here in Canada and we talk about quite a bit. And what we're talking about in integrated KT is this idea of partnership, active collaboration between researchers and research users in the research process. So integrated KT is actually about doing research. It's not necessarily about post-research dissemination. So because of that, this collaboration is something that can be done for research that's happening kind of at any phase of that, again, research to practice continuum. And so when we're talking about it, we're talking about working with your users to shape the research questions, decide on the methodologies you're using, developing data collection tools that work in their settings, as well as interpreting the findings and dissemination. And so partnering together to develop that, I believe, can really help us kind of sort of accelerate that partnership piece so that you're not necessarily getting to the end of your intervention and then having to find out if it's going to work in your setting. Integrated KT is one of those things that you hear a lot about. It's quite a bit of a buzz term, and certainly I think we heard a lot of integrated KT in Dr. Eng's talk, and we're going to hear more later today. It is one of those things, though, that everyone is just kind of doing and working with. So one of the things that I'm interested in increasingly is about understanding these research partnerships more and more. And so can we what makes a good partnership? Can we actively facilitate or intervene to help these partnerships move forward? And so we have a CIHR project grant to better understand integrated KT research partnerships in Canada over the next several years. And one of our first steps is a series of systematic and scoping reviews looking at how integrated KT is conducted. So what are the principles underlying it? What do people use for it? How do we, what are the outcomes and impacts of it? And we're doing this in partnership with Ian Graham's group, and he has a foundation grant as well, better understanding integrated KT. So that's one of the things we are working on our end. I am talking a lot, so I'm going to wrap things up here. So again, I hope what I have sort of sparked in you today is a little bit of thinking about how the research that you're doing, regardless of where it is, could be implementation-minded, and giving you some ingredients to kind of focus on or thinking about what your next steps might be. In particular, just figuring out sort of where's that next piece for me. A few resources for you. So our knowledge translation platform at the Manitoba Centre for Healthcare Innovation, because we're mandated to build capacity for knowledge translation, both practice and science. One of the ways that we do that is through an online blog. It's called Knowledge Nudge, medium.com/knowledge nudge. So we post weekly posts on kind of all things related to KT science, engagement, and partnerships in really sort of user-friendly, plain language, which is really interesting to write in as a researcher. But the idea here is that to make it really accessible, point people again to the right directions for here's the papers, here's the homework you need to do, and just kind of get people off on the right foot. So if this is something you're interested in, you might want to check that out. We're also on Twitter at Knowledge Nudge, and that's where we always sort of highlight when we have new posts there. Back when I first started working in this area, I wrote a primer for gait imposture because my mind was totally blown the first day of my postdoc when I started reading it, going, holy cow, this is a whole world of science and thinking that I had never been aware of beforehand. And so I had to fight with gait imposture to get this published. One of the comments was, this is not science. So please read the paper because I think this is what we want it to be, right? We want to take knowledge translation not just from a buzzword to having a strong foundation behind it. We followed that up a couple of years later with a case report in physical therapy on how we have conducted this whole series of studies applying the KT theories and frameworks to the practice. And so I think that is kind of one of the, I always think is one of the sort of neat things. When you read all of those individual publications about balanced assessment practices in physiotherapists, it doesn't say knowledge translation anywhere. It doesn't say theory anywhere. It's only when you back up and look at the research program as a whole that you can see that conceptual sort of foundation. And so kind of depending where you're focused on, that's where you can go through there. If you are really interested in diving into this deeper, Knowledge Translation in Healthcare is a textbook that originated in Canada, and we really do have some of the pioneers here and are seen as international leaders in the field. And I call this the Bible of KT. It kind of gives you like a one-stop shop of everything, so I refer to it regularly. So you may want to check that out as well. And with that, I